So now I have the pleasure of introducing our next speaker. Dr. Shaw is a thrombosis fellow at the Ottawa Hospital and the Ottawa Hospital Research Institute. He is completing a master's of epidemiology with us at the University of Ottawa, and he received his medical degree at the University of Ottawa and completed his internal medicine and hematology fellowship at the Ottawa Hospital. His research interests are in perioperative anticoagulation management and anticoagulation reversal. And it's a pleasure to have Dr. Shaw speak to us on the management of anticoagulant-associated heavy menstrual bleeding.
Hi, everyone. So thank you, Lena, for the kind introduction and the chance to talk to you guys today. So today I'll be talking to you about the management of anticoagulant-associated heavy menstrual bleeding. So these are my disclosures. I received research funding from the PSI Foundation. And I'll just leave this here for a few seconds for you guys to read. So just as an overview of my talk today, so I'll start with a case presentation to try and illustrate some of the learning points from today's lecture. I'll go over the definition of heavy menstrual bleeding and review how anticoagulation can impact the incidence and the severity of heavy menstrual bleeding. And lastly, I'll go over some strategies to try and mitigate anticoagulation-associated heavy menstrual bleeding. So for the case today, I'm presenting Olivia, who is a 33-year-old female. So she presents to an ER with sudden onset pleuritic chest pain, shortness of breath in the context of 5 days of right leg swelling, discoloration, and tightness. She's previously healthy. Her past medical history is unremarkable. She's a non-smoker, and she's not on any form of contraception. And on review of history and exam, you can't really identify any clear provoking factors for why she's presenting today. On exam, she's stable with a heart rate of 95 and an oxygen saturation of 99% on room air, and her cardiorespiratory exam is otherwise normal. CTPA is requested, which shows bilateral segmental PE, no radiographic right heart strain, and a right leg compression ultrasound is done because of her leg symptoms. So it's done the next day, and it is positive for a femoral DVT. So Olivia is diagnosed with an unprovoked DVT and PE, and she started on rivaroxaban 15 milligrams twice daily for the first 3 weeks, followed by a step down to 20 milligrams PO once daily. Now, after completing the first 2 months of rivaroxaban therapy, you see her in follow-up, and unfortunately, she mentions to you that her menstrual bleeding is much heavier than her usual, changing pads every hour and passing clots. So I'll start by going over the incidence of VTE. So many of you in the room know this, but we believe that the estimated incidence on average for VTE is around 1 event per 1,000 person years. Now that incidence tends to vary across different age groups, so it tends to be quite a bit higher among older patients and probably closer to 1 in 10,000 person years among younger patients. But we do know that the incidence of VTE tends to be higher among young women as compared to young men. And that's thought to be mainly due to reproductive risk factors like the oral contraceptive pill or pregnancy, for example. In terms of the definition of heavy menstrual bleeding, so for research purposes, it's usually defined as menstrual blood loss of greater than 80 milliliters per cycle. But a much more useful definition, clinically speaking, is any excessive menstrual blood loss leading to interference with the physical, emotional, social, and material quality of life of a woman. And I'm listing here abnormal uterine bleeding, which is a more recent definition. I'm going to be using this interchangeably with heavy menstrual bleeding throughout the talk, and abnormal uterine bleeding encompasses the different presentations that you can see listed there. In terms of the incidence of heavy menstrual bleeding, so it's thought to affect up to 30% of women, even in the absence of anticoagulation. And something that's important to keep in mind when you're considering the incidence of heavy menstrual bleeding is that it's probably underreported quite a bit. So many women affected by heavy menstrual bleeding may not necessarily seek medical help for their heavy menstrual bleeding. And I'm illustrating this on the right. You can see the results. This is a survey that was conducted of women across various European countries. And what I'm highlighting, the results in gray, you can see are the proportions of women who reported symptoms consistent with heavy menstrual bleeding, but who did not seek medical help, so did not consult a physician for this. And you can see the proportions varying between a third to even up to 2/3 in one of the countries. Something else that's important to keep in mind, so I am going to be talking about some data from clinical trials. And it's important to keep in mind that the impact of anticoagulation on heavy menstrual bleeding may not be fully captured in these trials. The reason being the ISTH definitions like major bleeding and clinically relevant non-major bleeding, they're often more focused on acute bleeding. And so they really fail to capture the recurrent and chronic nature of heavy menstrual bleeding, which is what leads to a lot of the morbidity in the first place. In terms of the impact of heavy menstrual bleeding on women, so we know that it can lead to iron deficiency anemia in a significant proportion of women, but it can also have a significant impact on the quality of life, both physical and mental, of a woman. And to illustrate that, so there was a questionnaire of Swedish women that showed that women with heavy menstrual bleeding were more likely to refrain from social activities. They were more often absent from work. And this survey also administered the SF-36 quality of life questionnaire to women. And I'm showing those results on the right. What you see is that the lower line are the women who reported symptoms consistent with heavy menstrual bleeding compared to women who did not, so the higher line. And the difference across all of these domains was actually statistically significant, being lower for those women with heavy menstrual bleeding. So just as an overview of how anticoagulation can impact heavy menstrual bleeding, so it can lead to heavy menstrual bleeding in the first place, but it can also worsen pre-existing heavy menstrual bleeding. It can lead to prolonged bleeding, and it can also lead to the need for interventions like endometrial ablation, for example. Specifically in terms of warfarin, so the vitamin K antagonists, depending on the study that you look at, reported rates of abnormal uterine bleeding are as high as 67% among women on vitamin K antagonists. And this one study in particular that I'm presenting here asked women to recall their menstrual bleeding patterns before being started on warfarin. And then they were started on warfarin and the menstrual bleeding patterns were reassessed. What the study showed is that warfarin led to an increased proportion of women who did report symptoms consistent with heavy menstrual bleeding. It increased the duration of menses in terms of mean number of days, and led to an increase in the need for medical intervention. So this were things like endometrial ablation or medications like tranexamic acid. In terms of DOACs, so first in terms of the direct 10A inhibitors, a lot of the evidence that we have comes from post-hoc analyses of pivotal trials that do indicate, I would say, that all direct 10A inhibitors likely have an increased risk of uterine or vaginal bleeding as compared to warfarin. So what I'm showing here, these are post-hoc analyses of the Einstein trial for rivaroxaban and the Hoxside VTE trial for edoxaban. And what I'm showing is that the direct 10A inhibitors were associated with an increased hazard of uterine or vaginal bleeding compared to warfarin. Now, in the case of the Amplify trial with apixaban, they did not identify a statistically significant increase. So the odds ratio there is 1.2 with a 95% confidence interval that crosses 1. So there didn't seem to be as much of an effect with apixaban in terms of increased risk of uterine bleeding. In terms of dabigatran, so a similar post-hoc analysis was conducted for the Dabigatran VTE trial, so Recover and Remedy. So these post-hoc analyses are focused on women of reproductive age, obviously, and what they identified was actually dabigatran was associated with a lower odds of abnormal uterine bleeding with an odds ratio of 0.59, and this was a statistically significant difference. So there may be a difference here in terms of the different class of anticoagulants, dabigatran being a direct thrombin inhibitor. In terms of management options for managing anticoagulation-associated heavy menstrual bleeding, just to give you an overview, management options generally fall into 3 different classes. So there's hormonal or contraceptive therapies, there's modifications to the anticoagulation regimen itself, and then lastly, tranexamic acid. So first I'll focus on progestin-only options in terms of medications that can be used, interventions that can be used to mitigate heavy menstrual bleeding. So the levonorgestrel IUD has been studied specifically for heavy menstrual bleeding, and what I'm showing here is are the results of a systematic review that generated pooled proportions of amenorrhea at different time points. So it does take a bit of time for women to develop amenorrhea in most cases. What I'm showing, so figure 2 on the left is showing between 3 and 6 months, where the pooled proportion at the bottom there was around 8%. But then if you look at closer to a year, that proportion tends to increase to around 20%. And you'll see there's a lot of heterogeneity in these estimates. So there are some studies that do mention even up to 50 or 60%. Even if women don't experience amenorrhea, the levonorgestrel IUD does result in significant reductions in mean menstrual blood loss, as well as increases in hemoglobin and ferritin. And a lot of this data is among women who are not on therapeutic anticoagulation. But there are some small studies, including a small randomized control trial among women who had mechanical valves implanted So they were started on warfarin, and they were randomized to either an IUD versus none. And that study did show that the IUD was effective in the context of therapeutic anticoagulation. In terms of other progestin-only options that can be considered, so there's the depot medroxyprogesterone acetate injection, subdermal progesterone implant, and the progestin-only pill. So these medications do lead to varying rates of amenorrhea. Not all of them are necessarily used for the treatment of heavy menstrual bleeding, although they can be used to reduce menstrual blood loss. Specifically, the progestin-only pill, so the low-dose progestin pill that's typically used for contraception should not be used specifically for the management of abnormal uterine bleeding. Generally, on that lower dose, it's fairly rare that women experience persistent amenorrhea, and actually, it's quite common that women experience irregular and unpredictable bleeding. So in the context of anticoagulation, that's not really something that you want to do. If it is used for the management of heavy menstrual bleeding, is typically at a higher dose. So for example, norethindrone 5 milligrams 3 times a day. And I'll be going over the different VTE risks associated with these progestin-only options. So there was a systematic review that looked at progestin-only contraception and the associated VTE risk. So this systematic review in the BMJ did not identify an increased VTE risk associated with the levonorgestrel IUD with a relative risk of 0.61. There are a few studies that have shown increased VTE risk with the depot medroxyprogesterone acetate injection. So even though it is a progestin-only option, because it's thought that maybe the levels of progesterone are quite a bit higher following the injection, that it may lead to this increased VTE risk. That was identified in that same systematic review, as well as another fairly large Swedish case control study. So I would argue that the DMPA shot should not be used in the absence of anticoagulation, and I'll be going over what I mean by that in the next slide. In terms of the subdermal progesterone implant, it's not typically used, as I mentioned, for the management of heavy menstrual bleeding, although can lead to amenorrhea in a proportion of women, and it has not been associated with an increased VTE risk. And for the progestin-only pill, the contraceptive dosing has not been associated with an increased VTE risk, but there was an older nested case control study published in the 1990s that did divide up the indication. So if you were using progesterone-only medication at therapeutic dosing for heavy menstrual bleeding, it was associated with an increased risk of VTE. In terms of the combined oral contraceptive pill, which I'll refer to as COC, so it is considered by many to be first line in the management of heavy menstrual bleeding. And it's fairly well established that estrogen-containing contraceptives are associated with an increased risk of VTE, with relative risks ranging from 3 to 5-fold. And for that reason, a lot of product labels of COC generally mention that it's contraindicated in the setting of active or prior VTE. But what I'll show with the next study is that this risk of VTE from COC might actually be mitigated by therapeutic anticoagulation. So this was a very useful study. This was that post hoc analysis of the Einstein trials. And what they tried to look at as well is among the women in the trials of reproductive age who were either on rivaroxaban or warfarin, they did an analysis. So this was a regression analysis trying to look at recurrent VTE depending on whether a woman was on hormonal therapy or not. Now, this could have been contraception or it could have been hormone replacement therapy. But what they found is an adjusted hazard ratio of 0.56 with a confidence interval crossing 1. So there wasn't any strong evidence that the women who were on hormonal therapy while on therapeutic anticoagulation, there wasn't necessarily a signal of increased VTE risk. The incidence density on hormonal therapy was actually lower at 3.7% per year as compared to 4.7% per year off hormonal therapy. So definitely no strong signal of any increased risk. And so the thought here is that maybe the therapeutic anticoagulation can mitigate that increased VTE risk from hormonal therapy. So what the authors of this study suggest is that you can actually consider continuing COC while a patient is on therapeutic anticoagulation. So I would say that's particularly relevant for those women who are started on COC for heavy menstrual bleeding in the first place. They develop VTE, and then when they're put on anticoagulation, their COC is withdrawn. So they kind of have this double hit effect in terms of worsening their heavy menstrual bleeding. So in situations like that, you can actually consider continuing the COC. But I would actually go a step further and say you can actually consider starting it as a management option for women with heavy menstrual bleeding induced by anticoagulation. But again, the premise here is that this VTE risk is being mitigated by the therapeutic anticoagulation. So if you get to a point in your treatment course where you think that the anticoagulation should be discontinued, then at that point you should definitely consider transitioning to an alternative non-estrogen heavy menstrual bleeding treatment, like the levonorgestrel IUD, that has a lot more evidence that it's not associated with increased VTE risk, even in the absence of anticoagulation. In terms of modifications to the anticoagulation therapy itself, so what I'm showing here are the results of a smaller single-center prospective study of women of reproductive age who were either on rivaroxaban or warfarin. This study similarly showed that women on rivaroxaban were actually at higher risk of heavy menstrual bleeding. Not only that, the study showed that women who happened to be on rivaroxaban were at had a greater odds ratio of having a short interruption of their anticoagulation therapy of 2 or 3 days. And then they went one step further and looked at if a woman was on rivaroxaban and experienced heavy menstrual bleeding, that was actually associated with a significant increase in the odds of recurrent VTE. So the authors of the study interpreted that as evidence that temporary interruptions of anticoagulation might be associated with an increased risk of VTE and should be avoided, especially within the first 6 months, because we know patients are at higher risk of recurrence during the first 3 to 6 months. In terms of switching between different anticoagulation options, so there are some limitations to the evidence here. So we are comparing across studies, but this is a relatively low risk intervention to undertake. So you're switching from one DOAC to another, for example. And so I'd say it's reasonable to consider switching from rivaroxaban or edoxaban to either apixaban or dabigatran, which may be associated with a lower risk of abnormal uterine bleeding. And a lot of these comparisons that I'm making here are comparing to warfarin. So it's important to keep in mind that warfarin may be associated with a lower risk of abnormal uterine bleeding and can be considered an option if needed. In terms of antifibrinolytic therapy, so just to highlight some evidence showing that it does work among women specifically with heavy menstrual bleeding, there was a relatively small double-blinded randomized control trial that looked at oral tranexamic acid. So these women were not on anticoagulation, and importantly, women with a history of VTE were excluded from this study. But they randomized women to either tranexamic acid or placebo. The dosing that they used was 1.3 grams 3 times a day for 5 days, for up to 5 days per menstrual cycle. And what they did show is that it was actually effective at reducing mean menstrual blood loss, and they did not document any thromboembolic events. Now, speaking of thromboembolic events, concerns do exist about the risk of VTE with tranexamic acid, but I would actually argue that several of the landmark trials that have looked at the use of tranexamic acid were among patient populations who are at very high risk of VTE. So if you think about trauma patients in the CRASH 2 trial, women with postpartum hemorrhage in the women trial, as well as several smaller studies looking at knee or hip arthroplasty, we know that these patients are at very high risk of VTE complications, and these studies have never really shown a clear signal of increased risk with tranexamic acid use. And here I'm presenting the results of a relatively recent systematic review showing pooled relative risks for venous and arterial thromboembolic events. And as you can see at the bottom, highlighted in green, so for each one of these types of thromboembolic events, there wasn't an increased risk of thromboembolic events with tranexamic acid use. So some other things to keep in mind, and I think one of the most important take-home points of this talk is education. So it's important to ask women if you're prescribing an anticoagulant. It's important to ask them if they do have heavy menstrual bleeding to begin with. It's important to make them aware that it can happen or that it can worsen while on anticoagulation. As I mentioned, a lot of the time women are hesitant to mention these symptoms. So if you open that dialogue and make them aware that it may happen, and also tell them that there are management options that are available, I think that's a fairly important point to keep in mind with starting anticoagulation among premenopausal women. As I mentioned, so heavy menstrual bleeding can lead to iron deficiency anemia. So it's important to test for iron deficiency and order PO or IV repletion. And then referral to gynecology can be considered if you suspect that there's a specific anatomic cause for the heavy menstrual bleeding, if you think that further investigations are needed, or if you think that this, a particular case may be refractory to medical management. That's where gynecology may come into play in terms of procedural interventions like endometrial ablation, for example. So just to come back to our case, as a reminder, Olivia was diagnosed with an unprovoked DVT and PE. She was treated with rivaroxaban and started to experience heavy menstrual bleeding on the rivaroxaban. So you discussed the management options that we mentioned today with Olivia, and she decides to trial COC for her heavy menstrual bleeding. She mentions to you in follow-up that her menstrual bleeding actually improves on the COC with subsequent cycles, and it had already actually improved with the drop from the rivaroxaban 15 twice-a-day dose down to the 20 milligrams once-a-day dose. At 6 months, so you perform risk stratification and you deem her risk of recurrent VTE to be relatively low, so you feel that you can stop her anticoagulation, and at that point you decide to also discontinue her COC. So with that, I'd be happy to answer any questions you guys might have.
Thanks for that great presentation, Dr. Shaw. While we're waiting for some questions to come in, and if anybody in our audience has any questions, please go to the microphones. I'll just ask, so the case you presented, I think, is a common scenario where a woman is started on anticoagulation and then develops heavy menstrual bleeding. What would be your recommendation for a woman who's already on some form of contraception and is diagnosed with DVT or PE? We often see from the emergency department or from family physicians that there's a suggestion to stop their combined oral contraceptive pill. And if you could comment on your practice with that.
Yeah, so as I mentioned, this is probably one of the most frequent scenarios that I've encountered, at least in clinical practice, where a woman is on COC for VTE, is on COC for heavy menstrual bleeding, and then develops VTE and is put on anticoagulation. And often the tendency is to withdraw that COC because of the perceived association with the venous thromboembolic event. But again, that study in blood that looked at the mitigating that risk of VTE with anticoagulation, it's a very useful study because it argues that in situations like that, you can continue the COC. And if anything, if you think that that's going to avoid interruptions in anticoagulation, I think that that's probably the best course of action in terms of avoiding, both bleeding and thromboembolic complications from interruptions to anticoagulation therapy.
Great, thank you. We have a question from our audience members.
Morning. Excellent presentation, Joseph.
Thank you.
I wanted to ask you, or just a comment or speculate on the issue of the reported association between rivaroxaban and the increased menstrual bleeding. And just from your review of the literature, I mean, it's something that kind of surprised us when we learned about it, and then it sort of, became not that infrequent. And do you think it's due to the formulation of the drug as a once-a-day agent? And if so, is there any literature on this in patients who are receiving edoxaban? Probably, not as widely used, but is something that we should be considering and maybe switching to a twice-a-day DOAC in order to kind of mitigate some of this? I mean, I don't know if there's any specific answers, but just wondered about your general thoughts. Thank you.
Yeah, thank you, Dr. Duquedas. Yeah, I mean, it is interesting. We always try and debate about why we perceive there to be a higher or lower bleeding risk with some DOACs versus others, and I don't think we really know the reason why. There may be tissue-mediated effects. So, for example, like GI bleeding we saw with certain DOACs. It could also have to do with DOAC levels. So maybe with the twice daily dosing, you get lower peaks and higher troughs. But the bottom line is that we don't really know. So, and I think that's an ongoing area of investigation to try and figure out why, the link between DOAC levels, thrombin generation, for example, and clinical manifestations. So, but again, it's a relatively low risk and fairly easy thing to do to switch between these DOACs. And so if you are running into trouble, it's something you can definitely consider doing.
Great. Thanks very much, Dr. Shaw.